I want to start by talking a little bit about the program that I manage at Department of Children and Family Services, which created the realization that we needed better communication with our hospitals. I'm the manager for medical case management services with Department of Children and Family Services. So to put it in perspective, once Jenny Feria and the hotline have received a call and created an investigation, once Paula Gamboa at the command post or one of the regional offices conducts the investigation, and if they decide to open up a case, that case may come to my team of line staff who will provide case management. Here is how it's a bit different for my staff. So the children that come to my section are the most medically complex throughout LA County. So in addition to whatever reasons that led them to be detained from their parents or to remain with their parents, but there be an open case, it could be physical abuse, sexual abuse, general neglect, medical neglect, domestic violence, whatever those normal reasons why DCFS may have to intervene. Now we add the complexity of a really medically fragile child. The children that we supervise in my section, for example, may be the children with cerebral palsy, with cancer. We have a lot of diabetic children, and I'm so sad. We just received a case of a 2-year-old with diabetes, and it's just shocking that it would be infiltrating our children at such a young age. Many of our children are terminally ill. We understand that many of our children will have a shortened life expectancy. So I have a very special team of social workers and supervisors that handle the case management for these cases. As you can understand, this is not it's typical case management, but with a twist. The twist is we cannot transport our medically fragile children. We cannot just put a child in a car seat in the car. We will have to arrange medical transport to pick up the child, transport the child, meet the social worker. We will have to have a specially trained caregiver for our child, not only perhaps trained in diabetes or trach care or G-tube, but also trained specifically with the child's direct medical providers. So with that, in January 2014, our former division chief, Jeff Gibbs, I say former because he has retired into the world of retirement in the past year, but he realized the need for enhanced communication between DCFS and the hospitals, because the hospitals, the social workers in the hospitals would receive the complaints from their physicians, that DCFS social worker just won't return our call. We don't know what they're doing about placement. We don't know, why they're not just detaining the child and taking the child into protective custody. On the DCFS end, we are not always clear on hospital procedures, protocols, and we just realized, Mr. Gibbs realized the need for enhanced communication. Out of that, in January 2014, he sent out a simple letter of interest to a few hospital social workers, some of the larger hospitals that we routinely work with, and said, I don't know if you're interested, but I'm thinking maybe we should all come to the table and talk. And you can see our faces and put our names and faces together. We can see you. We can share information. Our goal is to perhaps reduce those calls to the Child Protection Hotline that are not a new call about abuse or neglect, but more, I need to share this information. The hospital's saying I need to share this information with someone and I don't know how else to do it. So to reduce maybe the number of calls that needed to go to the hotline because they can share the information directly with the case carrying social worker, to reduce the hospital overstays. What that means for our kids is if we don't have a placement that is medically trained, we can't go pick up our child. That's really frustrating to a hospital who needs that bed for another child. So we found by working together, teaming together, sharing ideas, sharing information, we're more likely to, as a team, move the child into appropriate placement even sooner. I've had hospitals that I've worked with provide intensive caregiver training within hours of a request, because they have a need to have the child out of the hospital so they have a bed for another sick child, and we have a need to have a child into a placement where they're getting services. So that discussion took off January 2014. At this point, we hold a quarterly, what we call Hospital Advisory Board, HAB, if you would, we like acronyms, Hospital Advisory Board meeting. We invite whomever wants to come to the table. We invite various DCFS staff, our safe surrender specialists, because many times, especially the smaller hospitals, may have a question about how exactly to handle safe surrenders. At the last presentation, what Dr. Durfee was mentioning was we had the Office of County Counsel speak about this whole thing about warrants and how to remove a child and what a hospital hold means, because back when I started doing social work 20 years ago, if we felt like we needed to remove a child, we drove up to the home and we removed the child. Things are not quite that way any longer. I'm really glad that we now have to go through the process of going through court and requesting permission to remove unless there's exigency. And Mr. Hunter from the Office of County Counsel was really able to help me even get a clear understanding of what exigency means and how we can work more closely together. So the Hospital Advisory Board meeting is quarterly. The idea is really for that information sharing, cross-training, cross-education, so we can all be better informed and work more efficiently for the good of the children that we serve. I will have a sheet if anyone would like to sign up to receive more information or to get the invite for the next Hospital Advisory Board meeting, which will be in October. I will have the sign-up sheet probably at one of the front tables, or you're welcome to see me after. Thank you so much.